We'll just do a test so we don't have the same thing as this morning. Can everyone hear? Fabulous. Just wait for a few to sit down. Okay, welcome to the last innovation stage of today. I just want to take the opportunity to thank VIAR. This morning we got a little bit confused with the technology, but I just want to say that VIAR sponsored this innovation stage and just thank them for their contributions. So, back in my day in Newcastle, one of my ambitions for the tech sector was always to have wraparound services and truly deliver outcomes for people. Now, we tried for a long time to get integrated responder services in our communities. And now we have the partnership to actually achieve that. So for quite some time, we've been working with our partners in the ambulance service. So the ambulance service ACE, the chief execs, but then we got a new proposition in November where NHS Improvement, approached the tech sector to work with us on a coordinated response teams in the communities. Now, who was in the main plenary? Have you all been in the main plenary? You'll have heard that urgent care response teams are being set and funded by NHS England across all of your integrated care systems. This gives a great opportunity for the tech sector to start truly collaborating with our colleagues in health, hospital to home, avoiding that escalation of need, and really delivering what we say on the tin. This diagram here, this new model of care, can only be delivered if we start to really work with that coordination of response teams in our communities. So what's the problem? Ambulance services demands, we've had coroner's reports, the ambulance services demands during 999, we've seen so many waiting times of 14 hours, 16 hours, where you're in the community with a call on hold because the demand's been so much from our ambulance services. The creation of your urgent care response teams is absolutely fantastic that NHS England is funding 42, but they're only there 8 late. That's fantastic. But the response teams in our tech are there 24 hours a day. This is really our trial site, the way we can truly be integrated. Wouldn't it be great that we have whatever Amica 24 progress housing with your NHS badge on, because you're seen as a coordinated response in the communities. So the tech, we take those calls in, and I hear time and time again that coroner's reports have highlighted that people have died, there's been inappropriate handoffs from the call triaging, and we really need to think about what does good look like as we start to deliver these services in the community. So what does our work programme look like? We've been working, and you've got a nice team here of Rupert Lawrence, who's been leading our programme from TSA, our programme from NHS, but also Progress Housing, who are the trial site in the Northwest. So this is a great opportunity for us to start looking at the integrated call triaging, to start thinking about the coordination of our referral services into other services in the community, but most importantly, how do you link to your integrated care systems? Now, I don't know about you, but I've waited a long time for anybody to put tech and integrated care in one sentence. So I think we should all be proud that as we move forward with our NHS colleagues, we can truly make a difference. It's our time. So here's your panel, and I'm great, to welcome everybody along today. But to start the conversation and start the debate today, I'd like to welcome Steve Gates. Steve Gates is the Managing Director for Taking Care, and I really thank him for his contributions, not only to being a headline sponsor for the year, but his contributions personally to all of the work he does on our quality improvement programme boards. He leads the risk, looking at emerging risks, and he's a real contributor to the sector. So over to you, Steve, you'd like to come to the stage. I think we should clap. It seems all quiet.
Alison, thank you. As Alison has said, from a taking care perspective, we are deeply privileged to be headline sponsor here. And I think as Alison said, all I want to do is start the debate. And I think probably from our point of view, there are three reasonably unique elements about taking care. The first is, although we work across a whole range of commissioned contracts, most of our business, most of our customers, our loved ones, are in fact private pay individual customers. So what that means is we're looking after a nationwide network of private pay customers, which means that sometimes we can't rely on the local responder services that some of you can. And I want to talk about some of the challenges that brings us. Equally, because we're talking to consumers, we will probably invest in the next 12 months about £2.5 million in talking directly to consumers about technology-enabled care. So when we heard this morning about raising our profile with consumers, we're absolutely committed to doing that. So we have three what we call emergency resolution centres, and when we look at the data and some of the challenges we've got, I'm sure they're reasonably consistent with some of the things that you're seeing at the moment. One, our call handling times when we've got a category 3 or a category 4 emergency that's been referred through to the ambulance is getting longer and longer. And what that is inevitably meaning is that we are making more outbound calls as part of the deterioration policy to the loved one customer. And equally, both they and families are phoning us in as well to find out progress on the ambulance. So our call length is increasing and our call complexity is increasing. And again, I don't know if you found it, but certainly our experience post-COVID is that we seem to have people with a larger accumulation of health problems before they even start to come and join us. So again, we've got people who are managing multiple comorbidities before they come and speak to us even. And then finally, we are looking to work really much more closely with the ambulance service, as Alison has suggested. We're actually having ambulance service requests turned down at the moment. It's not simply that it's going to take them 8, 9, 10 hours. That figure over there, South West Ambulance Trust, that's a local one for us in Exeter. You can see their outliers there in terms of category 3 emergencies. We're talking up to 24 hours before they're getting to see someone. So we believe this is a real both challenge and an opportunity. We think there are some things that we need to do as an industry, as a group, that are really, really important. And in fairness, you've heard a fair amount about a number of them already. We do think that collaboration is absolutely key. I think every single one of us recognises the pressure that the ambulance services are under. So we need to work really hard to find different routes, alternative routes, new routes. We need to be really clear in terms of actually bridging those gaps and focusing on the outcomes. And let's not worry about any private-public mix either, for a reason I'm going to explain in a moment. So our view is that history is a place of reference and not refuge. So we shouldn't look over our shoulders and go, well, this is the way it used to work. This is the way it's worked for many, many years. We've now increasingly got to look forward, got to see how we do things differently. So absolutely delighted to start that debate about that, about which you'll hear now from a number of experts, including you saw her on stage just now, on the big stage, and she said that she would talk a bit more about how it's working in practice. But again, in terms of that public-private partnership, we as Taking Care absolutely delighted to be working with the Warrington team to see what we can provide locally. So ladies and gentlemen, Caroline from Warrington, thank you.
Thank you.
Thank you. So you know who I am. I come here from a provider perspective across both health and social care in Warrington, and have the privilege of leading a portfolio that includes an urgent crisis response team, a falls responder team and a care call service. So my conversation with you today is a little bit of an insight into how those things can be connected together, as well as a pilot that we're running with Steve's colleagues in terms of that collaboration between the private and public sector. So we're pretty familiar with the context. It's not great as tech providers. We're holding lots of calls. The waiting times are getting longer, and it's getting to the point now for me it's almost traumatic for call handlers. They're very lonely. They're often isolated from other health and social care services, and they're really bearing the brunt of those really difficult conversations. Our ambulance services, we know, are in crisis. Call lengths are getting longer and longer for Cat 3 and 4 calls, but we do have a new service offer now in terms of the urgent community response services that are an NHS service. They're made up of health and social care professionals, and as well as care colleagues that provide services to people in crisis between 8 a.m. and 8 p.m. Now you might say, do you know what, that's only 12 hours of the day. We operate over 24 hours of the day, but this is a significant investment and progress in terms of the NHS's contribution about crisis care in the community, supporting people to live well and independently at home and provide a real alternative to people going into hospital, where we know what happens for the majority of our clients who find themselves in hospital. They are often there for a long time, and often their needs are greater and they are more dependent at the point of leaving hospital than when they arrived. So these services are a real opportunity in terms of being able to do something different for that frail elderly population. So our collaboration is really one between the ambulance trusts and tech services providers, such that we're able to offer a different response to people when they find themselves in a crisis situation that doesn't look like dialing 999, finding themselves in an emergency department and then in hospital for several weeks. So our mission is really to work with the tech sector to provide personalised care for people at home and really transform this space so that people can access care at home, supporting them to be as independent as they possibly can be within their own homes. We know that there's a significant number of calls that come into ambulance services. These figures are for England, so apologies for anybody who is from another region. I'm sure we could extrapolate the data, but for illustrative purposes, we know that the volume of calls, even for the small number of deflections from the ambulance service, that we could support a significant more number of people at home in the place that they want to be. So there's a real evidence base for what we're trying to achieve here. Many of you are national providers, like Steve said earlier, and you're probably kind of going, well, it might be okay if I know where these urgent crisis response services are in my patch, but if I'm working nationally in a big control centre, kind of how do I find them? How do I get in touch with them? Our colleagues in the NHS have a tool called Service Finder. Some of you may or may not be aware of it. Essentially, it's a lookup tool where you pop in the postcode that your service user is in, and it will come up with a menu of services, anything from a dentist to a pharmacist to an urgent community crisis response service. So this is our method for being able to connect you guys with actually what's available there in terms of services. This is something that we're piloting, which you'll hear more about from colleagues shortly, in terms of we want to run some tests on not only this connectivity but also the decision support tool that Rupert's going to speak about. But this feels like the next logical iteration in how to better connect people who are in need with the services that are there for them. So locally in Warrington, we've been doing a few things, and mainly around 3 different pathways. So we've connected our urgent crisis response and what's called our care call service, which is our tech service, with our falls response service. So effectively now we've got 24 hours a day coverage in terms of a response to somebody in an escalated need. The falls responder service traditionally operated started overnight, as many of them do. We've leveraged some additional funding through our Better Care Fund to enable that to now operate on a 24/7 basis, so that whenever a call comes into our TEC service, they then have a range of choices, whether that be the urgent community response service or a falls responder service. So there's a better offer available now than what we used to see, was our TEC service feeling a little bit isolated and a little bit disconnected from some of the services that were actually available in the same town. We've had some great case examples where people have been supported at home. You can read them for yourselves, but essentially this is for me about bread and butter community care. You've probably realised it's my passion. It's very much my background as a physiotherapist in supporting people to be able to do as much as they can at home, and how we connect services and support people. In both of these cases, the outcome has been for both of these patients, and there are many, many more that we could choose from, but they have stayed at home and the ambulance has been stood down. So not only have we achieved the primary objective for the person who's receiving care, but also we're day in, day out able to actually avoid the use of the ambulance for category 3 and 4 calls, which means that our ambulance services are able to respond to those category 1s and 2s, which is where we know that's where we want them to be. So if we can even take a small fraction of these calls from the ambulance service, they can get to those priority cases much, much quicker and improve the outcomes for those people too. Steve mentioned about a collaboration with Taking Care. So what we are piloting, and this is our first pilot with Taking Care. We know that there's many other agencies out there we'd like to connect with, but we're testing out one first. So our work with Taking Care will mean that for the 100 people in Warrington who we know have TEC services through Taking Care, they were people who previously I had no knowledge of until we started having these conversations, and they didn't have access to any services in Warrington in terms of the traditional health commission services. So we are due to go live in just about 4 weeks' time, in such that the call operating centres within Taking Care will be able to contact services locally in Warrington and actually achieve the same level of response for those 100 people in Warrington that are Taking Care clients as anybody else in Warrington would be able to achieve. So as I say, this is probably one of the first public-private type partnerships that we've actually started on the basis of having a shared vision and a real commitment to actually supporting people to live well independently at home. That cross-cuts all sectors that we work in, so we're very excited to make this our first project, and really hope that we will then build on it and make the offer available for every client and resident within Warrington to have equitable access to the same level of personalised care. So you might be thinking kind of, right, how, what might I do next in my service? And I think it was mentioned earlier, get in touch with what services are available in your area. If your experience is anything like ours, there's pockets of services that have traditionally been commissioned in relative silos from each other, but the real prize for our citizens that live in all of our towns is being able to connect those services together so that people have a credible offer and an alternative offer to access care at home. So I'd encourage you to be a little bit curious about what's out there, and to really work together to actually forge some pathways between those services. Now, that's not to say at times we've had trials and tribulations of things like, this is my criteria, your criteria, I don't do that, I think I'm meant to do the other. So stick with it. It's not easy, it takes a lot of talking, it takes a lot of cups of tea just to get through those conversations about what could we actually do better by actually doing it together rather than doing it in splendid isolation for each other. So please do start those conversations. Happy to have the discussion, the debate, and anything that we've done locally that would be of any help to anybody, whether it be pathways, etc. More than happy to share anything with anybody if that would be helpful. Thank you. I think it's Rupert next, or back to you?
Thank you, Caroline. And I think from Caroline's conversations there and just what she's trying to do in Warrington, we need to do it everywhere, yeah? But the first journey for TSA is the first point of contact into the monitoring centre. And we know we haven't got any common data sets, we haven't got any, we need to get some consistency of how we receive those calls. So I would like to welcome our TEC Operations Director, Rupert Lawrence, and he's going to talk through our collaboration from the call triage and perspective. Over to you, Rupert.
So day one at TSA involved a meeting with our partners in a really great piece of work, which I think is just going to be such a fantastic collaboration and a key step change for the environment in which we provide our services in. I know from my own experience of operating a tech provider and seeing the monitoring centre team, working furiously, looking after people, checking back on deterioration, really looking at how they were supporting people that were in some quite dire circumstances, and you were seeing the pressure that the ambulance service was under. And these are huge impacts, not just in terms of resourcing, but in terms of the effect on people. And I think that going into a really collaborative approach, and Caroline mentioned collaboration so many times throughout her segment that really has stood out for me. But what I'm going to talk about is really the kind of practical steps that we're going to go forward with to actually achieve this collaboration and make it work, and let's get some better results coming. So wanted to talk around some of the journey that we've been on at TSA. We've got our Quality and Improvement Programme board, and one of the special interest groups I've been part of previously for quite a long time actually. The pandemic kind of hit and disrupted things a little bit, but we had a special interest group that was looking at emergency call handling and looking how we challenged ourselves to create better ways of doing this and coming up with some guidance for the sector. And that group worked really hard and really effectively to go through and find out what the best questioning techniques and best approach to call handling was. And you'll see that there's a link on this slide which if you're members of TSA, you can follow the link and download this guidance document that we're actually launching at conference. It's got some great content in there, some really great guidance for call handling, helping to work in more effectively with 999 call handlers, and it's a key output from that group. And something that is really going to help to raise standards across the sector in terms of our approach to handling emergency situations. But I mentioned at the start that this is all about a journey, and the next practical steps in terms of making the most of the opportunity that a new pathway like UCR presents to the tech sector. It's a really, really important moment, and something that I wish had been able to happen earlier. As someone who was running a service previously, if this had been available, it would have been really helpful, but it's important that we're on that journey. We have a new special interest group that's going to help us with the delivery of a new approach for use of a decision support tool. We're not calling it a triage tool. We're not making out that we're doing any type of clinical triage. That is something that is discounted from this, but it's all about the pathways. It's all about what support you can get for people. What are the different options, and what are the right options for people? What's going to achieve the best outcome for that patient? So we've got a decision support tool. We're going to have a group that's really going to focus on how that decision support tool is best to be embedded across the sector, how we roll that out nationally, and how that works with a more collaborative and innovative approach to response services, because this is where the magic with this comes in. We're seeing some great examples, and Joanne Busher from Progress is going to highlight some of this later on. Some great work where response services have collaborated with their partners in health and come up with something better, something different but something better, and we really want to take this work forward. So following conference we'll be recruiting to this special interest group, because we need to get some key people involved to help us to design this new approach. So UCR, a new pathway for call response. And when I was operating a service, I was fortunate to have a falls response service in my local area. Across Worcestershire, great falls response service, providing you with that option to be able to look after an uninjured faller much more quickly and in a supportive way, with all the correct signposting, everything like that. But it's really important that we have those options available as much as possible across the country, but then linking it to this new great service that we've got. So what we have been issued with is a challenge from NHSEI, a 100-day challenge for us to get started on a new approach to working with UCR and taking that pressure off the ambulance services. Key kind of focus for us in terms of taking some of those calls and routing them towards a new alternative pathway, and something that we can really make use of. That challenge has led to a working group being developed, and that's headed up by Alison. And this group has got key people from TSA sitting on it, but also partners across health and ambulance services and things, helping us to inform a group that is going to be looking to reduce ambulance calls from TEC. And I think that the key thing that jumped out to me was at the start of the first meeting, where we saw that the number of calls each day going to the ambulance service from TEC providers, 2,600 is actually a huge amount. And even if we can bring that down by 1%, you imagine the difference that is going to make to the ambulance service across the country. It does vary from provider to provider, but there are significant impacts that we can achieve. And we see that challenge and what it presents to providers. I heard it in day one in my role. I had providers contacting me saying, we are really struggling. We are seeing the impact of the callbacks and having to consistently be checking back on deterioration, and that really having an impact. But not just pressure on resourcing, really impact on people, stress and anxiety. We've seen it. We've been trying to help organisations coping with that. But what we're looking at is something that's hopefully going to alleviate some of those pressures. But we've got to take providers on a journey to be able to do that. So we've come to the development of a tool and the development of a field trial to be able to test some of this out. We looked at some of the tools that have been available already, that have been used in different scenarios, but what we've actually come to is a point where we need to actually develop our own bespoke tool for TEC service providers, because they need something that works within a monitoring centre. I always used to say to my old team, you've got to think how these things look at 3 o'clock in the morning or 7 o'clock in the morning. It's got to be able to work and make sense for an operator. So we've really got to test these things out. So we've gone through some initial phases in terms of designing the tool and making sure that we process injuries and illness situations correctly, and making sure that we feed in that additional pathway of UCR into a workable and usable tool. Looking at the field trial that we're going to be commencing hopefully in June, that's when we're looking to do this. We're going through development phase now with a tool. We'll be developing the training, because it's important that we can roll this out to the field trial sites. And we're looking to do that with 2 sites originally, and Progress Lifeline being one of those, and we're really grateful to them for coming on board with this and really engaging with us during the development phase of the project and beyond. But the key thing with this is that it's going to be a fully evaluated trial as well. There's going to be different stages to the trial. We're going to start off small with a couple of services, focusing, getting things right, working out some of the creases in it, because there inevitably will be. It's a different way of working. We've got to make sure that we've got all of the referral pathways and agreement in place. We've got to make sure that the information is working correctly on the directory of service and NHS service finding. But all of these things we've got to make sure they go right. We'll then extend the trial out. We'll be looking to roll that out to different areas of the country, and then developing the information around the tool and our experience of operating the trial forward into its adoption into QSF, into the quality standards framework, so we can then achieve a national rollout. And we've got some real pressure on this because of winter pressures, and we need to get it in and operating as soon as we can. So as Caroline mentioned before, speak to the services that are around you, be curious and find out about those services, because we're going to be doing this, and it's going to be such an important development for us. So I'm going to hand over to Joanne from Progress Lifeline, who's going to talk about a bit more about Progress's journey with response and call handling. And again, just really delighted that Joanne and all of her colleagues at Progress are going to be helping us with this work. Thank you.
So good afternoon. Like Rupert said, my name's Joanne Bushell and I'm Head of Progress Lifeline Operations. So Progress Lifeline is part of Progress Housing Group. We're a non-for-profit organisation, and we're very keen that every opportunity money is put back into the organisation to support our service users. Picking up on what Rupert said, we have been operating for more than 30 years as Progress Lifeline. We currently have just nearly 70,000 customers. We have a full managed service, from referral straight to responder service, installation and everything. And especially what has been emphasised today, especially Alison, we also have a wraparound service. We do the 24-hour telecare monitoring. We have emergency home responders. We actually have 50 emergency home responders that work in teams geographically. We do cover national service, but we started off in Lancashire in the year 2000 as a result from feedback from our ARC back in 2000 about ambulance delays. So our director listened to what the staff was saying. Lorraine, we're waiting an hour. Wouldn't that be great now? So what Lorraine did, we set up a response service. We do assisted lifting as well, and we also have out-of-hours contracts as well as with local authorities. Our emergency home responders, we support, out of them 70,000 customers, we support 23,000. We do welfare checks. So we roughly get around 69,000 calls a month from alarm activations. Out of them 69,000, we actually only send 0.6% to the ambulance service at the point of activation in the ARC. Average is around 4 to 6% if you don't have a responder service. It's already been mentioned the pressure that puts on the ambulance service. Myself and some colleagues attended Project X 3 years ago with the Department of Health, and I've got to say that there was a little bit of criticism from our ambulance colleagues regarding the amount of welfare checks that they get through. So picking up again what Alison said, if we can reduce that to what we do with 0.6%, that would have a massive impact on the ambulance service. We also do referrals. So when our responders attend, they also do automatic referrals to our falls prevention teams. That's took some years to build up that relationship with falls preventions across the whole of the NHS within our current location of Lancashire, but we've got a really good robust system now with that prevention. We also look at customers that use the activation quite a lot with the responder service, and we work with our partners to ensure that they have referral processes in place if they need third sector, Silverline, Age UK, and also in the out of hours emergency duty care. Currently, we respond around 1,000 to 1,300 a month on average. Out of that 1,000 up to 1,300, we respond to around 70% falls. Back 4 or 5 years ago, that were 40%. So we've already hearing about the ageing population and older people and frailty. We are now doing 70%. So around 900 last month of our responders was falls. We successfully lift around 70%. So quality service. It's very important that it is part of the QSF, the work that we're doing, because we then be consistent with our call triage tools and our decision support tools that are coming in. We're very proud that we are up for a finalist for 2 awards tonight, and I'm glad that I'm doing this presentation today, because if it was tomorrow and we were successful, I might not look as bright. We have had a contract with our local authority for a number of years for a responder and falls and lift service. In 2019, we were very proud to be part of a commissioned service with Health and Social. So Health and Social did actually get together in a room to argue about the budgets and then did come up with a commissioned service. And we were very fortunate that we won that service. So that was CCGs and local authority combined to give us a commission contract for responder and falls and lift. Part of that was really working very closely with our North West Ambulance Service. The North West Ambulance Service actually do direct referrals into the ARC. That is, every person in Lancashire has access to Progress Lifeline, even if they don't have telecare equipment. So if a caller comes through to the North West Ambulance Service, you've heard a lot of mention of category 3 and 4s. If they fall into that category 3 and 4, North West Ambulance Service will give that call directly to us in the ARC and we will respond. So this to me is a true collaboration of working with Health and Social. So every person in Lancashire has access to a full service, whether they have telecare or not. Part of that process has been really working with the ambulance. So what we'll do, we will attend the ambulance, it'll give us the call and we'll attend the scene. If our responder thinks there might be a minor injury or something they're a bit unsure of, we actually have access to the clinical hub in the ambulance service. That direct contact from our responder into a clinician that can give them advice or give another referral pathway, such as a district nurse, means that frees the ambulance having to attend. We're all well aware as well that the longer a patient is on the floor, the more chance that they will need conveying to hospital as well as admitting. Some of the work we did with the ambulance service during COVID was that we met on a monthly basis to make sure we could support them as much as we could. And one of that was actually that they would now refer Cat 3s with minor injuries because we had access to the clinical hub, and that gave confidence to our responders to be able to access that clinical information. To ensure that we could get this partnership with North West Ambulance Service, we had to go through the clinical governance framework. Even though it's a non-clinical, we had to make sure we were compliant with NHS standards. That meant that we had to go to a medical directorate governance within the ambulance service. We had to prove that our staff were safe, efficient and properly trained to make sure that we could pick up their patients. That took some time. It kept going back and forth with more evidence. It did eventually build in the confidence that when we first started in 2019, the ambulance was giving us 3 to 4 referrals a month. We're now up to around 130 referrals directly from the ambulance service. Out of them 130 referrals, we only send back 6% back to the ambulance. We also had a pilot with Tameside Digital Hub. That pilot involved our responders going out to a service user and using a Surface tablet to directly speak via the tablet to a clinician within a digital hub at Tameside. Our responders also took out oximeters and other blood pressure to be able to check on vital signs. That also assisted the digital hub in their clinical decision on whether it was appropriate to lift that patient. That again gave our responders confidence, but more importantly, it gave the digital hub clinicians confidence in the service that we was delivering. Caroline touched on the directory service. I've been in the NHS prior to this. It used to be called Doris, it's now DOS, and it's got different names. We actually get direct referrals from the 111 service using the directory service. So Caroline's already explained, they're looking, 111 will see it's a fall, non-injury, direct straight to our ARC, and we send our responder out. We're very excited to be part of the field trial. Continuous improvement and call handling is really key to making sure that the service user gets the right care, the right place at the right time. And that's what it is all about. It's very important that we use this opportunity with Rupert and the TSA to collect data, to make sure it's evaluated, so we can talk to our health colleagues with stats that make difference to them. Because as anybody will know, it'll be, well, what's in it for me? What difference are you going to make in my life? So if we can produce the statistics that I've already talked about, with 0.6 going through to an ambulance with an effective decision support system, then we can evidence it during the fields. Okay.
Brilliant. Well, I don't know about you, but there's some great work going on with the North West Ambulance Service. We need to get certainly back at my North East Ambulance Service on the same trials. So what's next? So you'll see, I don't want to put some endless dates where we say we're going to do with no deadline. We've been given a deadline by our colleagues in the NHS, and Catherine sitting over there as co-chairs. We have a 100-day challenge, a 150-day challenge, but we need to get through this field trial, lift it and shift it, get it into QSF and delivery for the winter pressures. I feel quite confident after listening to Caroline and to listening to Steve and Joanne that we're actually going to do this, and we're going to be able to share it with everyone in this room, everyone that's QSF certified, and take it forward. So the trial sites will commence in June, but we've already started the work. We've already linked it with the NHS DOS. You're seeing that that's all happening. Now it's just getting that the tool ready to be able to test it at Vane. One of the key things we need to do is with our platform providers. Will the tool integrate with our platform providers? Well, I'll leave it up to you all to go back and ask them. Yeah, that's our challenge. We really need it integrated so we can start to integrate with our colleagues in NHS. QSF adoption, this will be mandatory within this process. You've heard on the main stage that the CQC are working with us in QSF with their new frameworks. We've got to drive quality and safety, and it's no good us working in collaboration when we can't put that certified quality stamp on there and say you're able to test what you do. Because we've got to make sure that whatever you're doing in your ARCs and in your responder services, it's meeting the quality framework. We'll publish evaluation. Now, our sector's never good at evaluation, but we've got the tools and the support from our NHS colleagues to really make this work. So by November we'll have that, and we'll roll this out in January, and we'll come back next March with a lot more of our responder services all linking in with the new framework. So I think this is really exciting. So I really thank you everybody for doing that. And I want to just close this stage. We're going off very differently this year because there's so many organisations went through the QSF during COVID. There's too many of them to get on that stage tonight, so we're having a private celebration at 6:30 where we've got all of our senior guests coming along to congratulate the people who have quality and safety at the heart core of their organisations. How incredible in COVID that they've actually achieved this. These are the ones that are currently going through the journey, so it doesn't stop. We used to really have to push people to take a quality journey. When is it the right time? Have I got the resource to do it? Well, you'll see from Progress and our colleagues in Taking Care and Warrington going on the journey, it drives you to quality improvement and drives you to new behaviours. So I'm really, look at all those new organisations, care companies and others embracing our journey. But there's a new trailblazer being launched today and the work's going on in April, and that's for proactive preventative care. You'll see some of our certified members already, but some of the new organisations that are starting to look at what does proactive preventative care really mean and what are the changes that we need to be doing in terms of QSF. Now I think that deserves a real round of applause for our QSF members. I have no questions because you're probably just going, wow. But this morning when I chaired, we did have some questions that I would like to give to the panel, and it was more about a responder service and do you give personal care? It's been the veil of my life since I've been in technology-enabled care, but it's a big question. So over to you, Joanne. Do you deliver personal care?
No. So what we deliver is emergency care to make sure we can do a successful lift. And we've had lots of conversations with CQC about this to understand what we actually do. So we deliver emergency care to make sure that then that person can be lifted successfully.
Okay. Over to you, Steve. Do you deliver responder services in the community?
So in fairness, yes. And in fact, you can hear more about it tomorrow.
Okay.
Because for the London Borough of Bexley, we work with St John Ambulance.
Okay.
And they provide that, again, but it's very clear, emergency lifting care provided by a medically trained individual who can refer on to the GP and social services, but it is that lifting response that's key.
So this is the bit in Scotland, responder services are regulated, in England and in Wales they're not. We will be picking up this piece of work with CQC as they start to deliver their quality framework and moving on. They want to test it, why not in this major project? And one of the other big outcomes from the project is data. I remember those call reasonings on your monitoring platform, and I used to say, how many? And there was hundreds of them. Every operator used to create a new call reasoning. We're going to test some of the data, the common data sets across the whole of the tech sector, and we're going to test it in vain in this project. Because until we start collecting coordinated common data sets in tech, how can we share it with our colleagues in social care and in health? We've got to really ramp this up and make sure that we say what's on the tin. And when we roll this out into the communities through QSF, there will be that common data set as we're going. Please, as Rupert said, the project is going to take off, but we need people to come into our special interest group, which will be forming in April and May. I want us to get a community that you don't need to be doing lots of work, but we need you to engage and critique. So please join that, and I can see lots of nodding heads. It's something we need to challenge back at base, back in Newcastle where I live, our ambulance service, how can we work together? So thank you for this afternoon. I'm really looking forward to the gala dinner tonight. Everybody getting their awards, and we will party tech sector because we've done everything in this pandemic, and for the first time in a very long time we've truly got a voice across health, housing and social care. So well done, and go and get yourself and your glad rags on, and we'll see you back for the celebrations later. Thank you.